Good evening and welcome back to the Lipid Panel. My name is Dr. Guy Mintz and I am the Chair of Programming for the Lipid Panel. The Lipid Panel was conceived as a lipid clinic conference on a national scale. For those of us lucky to have a lipid clinic in our hospitals, it's a great opportunity to present cases to others across the country that may not have that same opportunity. So in this series, we review common presentations of rare diseases, atypical presentations of common conditions, sometimes even common presentations of common conditions, and we try to cover as much and as many important clinical topics that every lipid specialist needs to know. The series is meant to be a monthly coming together of rising stars, introducing fellows, medical students, lipid scholars that interface with esteemed faculty. If anyone has a case or a topic they'd like us to present, please email Chloe Mativi, Mattivi, at lipid.org, or reach out to me, and we're happy to do that. This evening, we have a superb panel led by Dr. Alan Brown. Dr. Alan Brown is our moderator. He's an interventional cardiologist and preventive cardiologist. He's currently professor of cardiovascular medicine, Wake Forest University School of Medicine, and recently retired director of the Lipid Clinic at the Advocate Lutheran General Hospital. Dr. Brown has served as governor and president of the Illinois chapter of the American College of Cardiology. He was also chairman of the Board of Governors for the American College of Cardiology in 2004. He's a master of the National Lipid Association and served as president of National Lipid Association from 2018 to 2019. Dr. Brown has authored numerous articles in the field of lipid management and prevention. He is also the host of Lipid Insights and Heart Manners. Our case presenter tonight is Dr. Natasha Vartak, who's a certified lipidologist and hospitalist at Northwell Health South Shore University Hospital. She completed her internal medicine training and a year of preventive cardiology at Lenox Hill Hospital. Dr. Zahid Ahmad is an endocrinologist who specializes in lipid disorders in both clinic and research. His focus is on genetic lipid disorders such as familial hypercholesterolemia and familial chylomicronemia syndrome. Dr. Archna Bajaj is assistant professor at the University of Pennsylvania with clinical and research interest in inherited lipid disorders, cardiovascular disease, risk reduction, and development of novel therapeutics for cardiometabolic targets. Dr. Bajaj is director of clinical trials at Penn Center for Preventive Cardiology. She serves as an on-site principal investigator in multiple clinical trials. She also leads the lipid clinic at the Philadelphia VA Medical Center. So with that, let me turn it over to Dr. Alan Brown, our moderator, and our esteemed faculty for this evening. Thank you.
Thanks a lot. I appreciate it, Guy, and I'm really honored to be on a panel with such fantastic colleagues. I've had the privilege of working with everybody. I just met Natasha, who I'm sure is going to impress everyone. And it's just we just have an amazing group of people tonight. So I'm looking forward to their insights, and it's an honor to be asked to moderate this webcast. We're going to be talking about untangling triglycerides, insights from the lipid panel. And in particular, we're talking about severe hypertriglyceridemia tonight and how to think about it. So we're going to start with the basics of triglyceride metabolism. And Dr. Vartak is going to take us through the basics, and I will, dig a little bit deeper on a few items, and then we'll get started on some cases.
Yes, thank you, Dr. Brown. So I wanted to start by talking about the differences between exogenous lipid metabolism and endogenous lipid metabolism, and I'll go into more detail in my next few slides. But just as an overview, when we say exogenous, we mean lipids that start in the intestine and then eventually make their way to the liver. And when we say endogenous, we talk about lipoproteins that are formed in hepatocytes. Next slide. And I'll also be reviewing lipoprotein lipase, or LPL, and its role in formation of triglycerides and free fatty acids. So starting with exogenous lipoprotein metabolism, when we eat food, it's made up of protein, carbohydrates, fiber, and fat. And when we start chewing, it interacts with our saliva and gastric juices. And then the food starts to break down into large fat globules, which make their way through the gut, interact with intestinal lipases, and break up into smaller fat globules. By the time they come to the small intestine, they mix with bile and form small lipid droplets, which can then be converted into mixed micelles, which is a small form. And now this can interact with enterocytes, and you can have your fat absorption begin. So the sterile components, free cholesterol, plant sterols, these all have to find their way into the cell. One of the enzymes that we can go to the next slide. One of the enzyme that does this is NPC1L1. This is what ezetimibe works on. And after the fats get packaged together with apolipoprotein B48, they're put together by an enzyme called MTTP, and then they eventually form these triglyceride-rich chylomicrons, which are then released into lymphatic channels. Next slide. The lymphatic channels then feed into the thoracic duct in the chest and ultimately into the superior vena cava. This way it bypasses the normal portal circulation, and chylomicrons can pass through circulation without passing the liver. So these large triglyceride-rich lipoproteins then have to be cleared from circulation. And the most important way that they get cleared is passing through capillary beds, where they then interact with lipoprotein lipase, which is in the capillaries and interacts with these triglyceride-rich lipoproteins. LPL hydrolyzes the fatty acids from them, and then you can store this fat in adipose tissue or use it for energy utilization. Ultimately, these particles are then condensed into chylomicron remnants, which then can be cleared by triglyceride-rich lipoprotein remnant receptors and hepatic lipases. Next slide. And switching gears to endogenous lipoprotein metabolism, you have your ApoB containing lipoproteins inside the hepatocytes. And if there's no substrate around for them to make a VLDL particle using hepatocytes, the particle gets recycled. And what drives VLDL production by the hepatocytes is your availability of fatty acids. So fatty acids can be delivered to the liver by chylomicron remnant particles, and then there can be hepatic de novo lipogenesis. You can also get fatty acid lipolysis from the periphery that carries fatty acids to the liver. So really, fatty acids are driving VLDL production, and once in the circulation, these VLDL particles are going to be cleared the same way that the chylomicron particles were cleared. The VLDL interacts with lipoprotein lipase in the periphery. Again, your fatty acids get hydrolyzed, and these particles become small enough so the ApoB component that's present on them can interact with triglyceride-rich lipoprotein receptors and LDL receptors for enhanced clearance. Next slide. So I wanted to read an audience response question. All of the following mutations occurring in a biallelic fashion can lead to familial chylomicronemia syndrome, except ALPL, B ApoA5, C ApoB48, D ApoC2, and E GPIHBP1. So please go ahead and vote what you think. Interesting mix of results. So maybe Dr. Brown, you want to take over and talk about these proteins that are involved in FCS?
Yes. Okay, so let's do that. So these are the genes, the proteins, which genes code for, that are required for lipoprotein lipase to work properly, and therefore for triglycerides to be removed from chylomicrons and VLDL. So lipoprotein lipase itself has to have a normal gene. So the lipoprotein lipase is made in the adipocytes and myocytes. The gene for it has to be functional. And then once the lipoprotein lipase is made, it requires a maturation factor called LMF1, or lipase maturation factor, which ensures that the intact lipase gets folded in the proper fashion to make it active. Then the lipase is secreted out into the interstitial space, but as you now know, it has to get into the endothelial lining of the capillaries in order to be available for circulating lipid particles. And the GPI-HBP1 transports by reaching down sort of into the interstitial space, grabbing the lipase and swinging it into the capillary lumen. So that requires a normal gene for GPI-HBP1. ApoC2 is an apoprotein on all particles with triglycerides, and it actually is required to activate the lipoprotein lipase. So it rides on the lipid particles and encounters the lipase in the capillaries and activates it. And then finally, ApoI5 is an important cofactor that holds everything together in the right configuration for lipolysis to occur and for ability to remove triglycerides. So very quickly, this is a drawing of the LMF1 protein and also the lipoprotein lipase being formed at the level of the ribosome. So here is the lipoprotein lipase as it is born. And of course, that has to be normal. And then as it is interacting with LMF1, it gets folded into this functional homodimer, which is the active lipoprotein lipase, and then exits the endoplasmic reticulum and ends up in the interstitial space between fat and muscle cells. Keep in mind, this is produced in fat and muscle cells. In this diagram, you can see the myocytes and adipocytes down here, and the GPI-HBP1 protein, which swings down, grabs the lipase, and swings it back into the lumen. And in the capillary lumen, here's a chylomicron with the ApoC2 on it that is turning on the lipase. So we've learned a few ways you can get screwed so far, which is a lipoprotein lipase gene has to be normal. The lipase maturation factor 1 or LMF1 gene has to be normal. The GPI-HBP1 protein gene has to be normal. And ApoC2, the gene that codes for that ApoC2 protein, has to be normal. And remember that chylomicronemia syndrome is a recessive trait, so any two of those mutations can lead to FCS. And then the final piece of the puzzle is ApoA5. And ApoA5 is delivered by HDL to the triglyceride-rich lipid particle, whether it be chylomicron or VLDL. And it sort of acts like a fork to hold everything in the right configuration for a lipoprotein lipase to remove triglycerides from the lipid particle. So those are the 5 genes that we look for in terms of mutations when we're trying to diagnose familial chylomicronemia syndrome. And of course, there could be heterozygotes that also have significant triglyceride abnormalities, but FCS, an autosomal recessive disorder, requires both alleles to have mutations. So the ARS question, the right answer would be ApoB48, which is not required for lipoprotein lipase activity. So with that background, let's talk about some severe hypertriglyceridemic cases and how to think about them with our fantastic panel. I would just point out that we're not talking about the moderate triglyceride level patients running, say, from 150 to 500, where the major risk is coronary artery disease. We're talking about people over 500, severe hypertriglyceridemics, where our concern is pancreatitis. And maybe we'll have a chance to talk about how you decide based on their disease, how much risk there is for atherosclerosis in these patients. So here's the first case, a 42-year-old. This case is actually from Dr. Erin Mikos from her clinic, and I am grateful that she submitted it. Patient had severe hypertriglyceridemia for 20 years, type 2 diabetes for 10 years, recurrent episodes of pancreatitis with her first one at age 18. She had a total of 10 pancreatitis episodes, including 3 episodes in the first year after her pregnancy. She had very high triglycerides, fasting anywhere from 1,200 to 10,000. And this would here are the labs she had when she had her last episode of pancreatitis. You can see her triglycerides were 5680. Cholesterol was 1,070. HDL was 21, and her hemoglobin A1C was 8.2. So before we go on, maybe I will start with Zahid. How do you think about a patient like this? And if you had to take a guess at what the underlying disorder was, what would be your thought process?
So I typically think about these by starting with, do they have any secondary issues? There are a lot of clues here as to what's going on. I always try to distinguish multifactorial chylomicronemia syndrome from familial chylomicronemia syndrome. This person has had the high triglycerides for a very long time, and has had pancreatitis at age 18. But if you look at the cholesterol triglyceride ratio, that kind of says that this is a mix of VLDL and chylomicrons more than just pure chylomicrons like in FCS. And this person has diabetes. This is always confusing because did the repeated episodes of pancreatitis cause diabetes, or did this person have diabetes first, and the high glucose levels, cause high or associated with high triglyceride levels? But those are my first thoughts, at least.
Okay, Dr. Bajaj, any additional thoughts?
Yeah, I agree with Zahid. Just thinking about presence of chylomicrons, whether it's multifactorial chylomicronemia syndrome or FCS. I mean, when you have triglyceride levels well into the thousands, you're dealing with chylomicrons, and really that's the risk in chylomicronemia syndrome, is that those chylomicrons can lead to acute pancreatitis. And I think a couple other triggers to note is 3 of those episodes were postpartum, and we know that triglycerides can be elevated during pregnancy and the postpartum state. And so just thinking about certain triggers like that.
Makes sense. And Dr. Vartak, any thoughts?
It's just interesting to see that her severe triglyceridemia ranges from 1,200 all the way to 10,000. So it just gives you an idea of the numbers we're dealing with.
Yeah, and we all see diabetics with 8.2 A1Cs walk in the office. They don't have triglycerides at this level, right? So I think it's an interesting case. And, I believe all of us on the panel start by thinking what kind of particles could be there. And Dr. Ahmad pointed out that the ratio is about 5-1. So chylomicrons have 10 triglycerides to every cholesterol. If it's pure chylomicronemia, the ratio is somewhere between 8 and 10-1 usually. I mean, this isn't a perfect rule, but you can get a clue by looking at the lipid profile. And this is closer to 5-1. So that means there's other particles probably diluting the ratio of triglyceride to cholesterol. And so it smells like there's probably something else going on, not just chylomicronemia.
Alan, can I make one other point? Because
Sure.
I hear the trainees say all the time, oh, the A1C is 8.2, it's not that bad. And that's true, it's not that bad. But remember, triglycerides vary a lot, and so does glucose levels. So your A1C could be fine now, but that doesn't mean the last week or last 2 weeks your glucose levels were okay. I mean, we see people all the time who run out of insulin, and they end up in the hospital 2 weeks later with hypertriglyceridemic pancreatitis and a glucose level of 500. But if you check their A1C, it might be 7.5 or something. It's not that bad. So just be careful about putting too much weight into an A1C.
Yeah, that's a great point, and I think this case really illustrates that. But don't you guys think there probably is something else going on beside the diabetes to see these kind of numbers? We may never figure out what it is, but possibly some underlying genetic disorder with the diabetes on top of it exacerbated the severe hypertriglyceridemia. All right, so let's go on. A patient was referred to Dr. Mikos's lipid clinic. Her initial triglycerides were over 3,000, and they started her on nutritional counseling. And we'll talk in some detail about what that counseling should be. She obviously got started on a fenofibrate statin, and I assume she may have been on niacin before. I doubt any of us would put her on niacin, which is going to aggravate her insulin resistance, even though theoretically it could lower triglycerides. I certainly don't use it anymore, and if anyone else feels differently, say so. And then omega-3 fatty acids, and with the diabetes, one might choose icosapent ethyl because of the outcome data, and interestingly, MCT oil. So with those medications, her triglycerides came down to 756. She had a single mutation, so she was a heterozygote for lipoprotein lipase, but not since FCS is a recessive disorder, she would be a carrier, but would not have FCS with just that single mutation. Most of those patients have mild to moderate hypertriglyceridemia, so hers was quite a bit higher than you would expect. And then you could see that they treated her aggressively for her glucose with, for A1C with semaglutide, metformin, the MCT oil, ezetimibe, rosuvastatin, and fenofibrate. And certainly could have considered omega-3 fatty acids, which she was on previously. And then take a look at what happened to her lipids. Triglycerides came down to 149. So maybe I'll start with you, Dr. Bajaj. What does that tell you, when you see those kind of results with treatment in terms of what the underlying disorder might be?
Yeah, my first reaction is even without seeing the genetic testing is that, we usually don't see such a strong reduction in triglycerides in true FCS, right? I mean, this is quite a range to see that high of up to 10,000, but now down to triglycerides of 149. Traditionally, with traditional triglyceride lowering therapies are usually ineffective in FCS. So you're not going to see such a dramatic reduction. So even without that genetic testing, I'm already thinking this is more like a multifactorial chylomicronemia syndrome picture.
Right. I certainly would concur with that. And Dr. Vartak, any thoughts what this patient's ApoB level would be had we drawn it?
I would guess it would be on the higher side.
Yeah, so we're ApoB when we order it is ApoB 100, and we've already guesstimated that there's probably remnant particles and VLDL remnants, VLDL particles in addition to chylomicrons. So, and I'll ask you, Zahid, how would that separate this case from FCS as far as the ApoB levels?
Yeah, okay, so most FCS patients will have a normal or somewhat lowish ApoB compared to most MCS or multifactorial patients will have. I mean, there's an overlap, but most MCS patients have a higher ApoB level, and so it can help distinguish. It is a distinguishing factor if you're not sure of what's going on.
Yeah, it was actually in our scoring system that, most people with true FCS, homozygous or double heterozygotes, have relatively low ApoB for what you'd expect based on their lipid levels. And the reason Dr. Vartak, to her credit, already explained, which is that when the liver makes VLDL particles, about 75% of the cholesterol and triglycerides required to package a VLDL from the hepatocyte comes from chylomicron remnants. Those remnants are picked up by the liver, and then the liver uses those building blocks to make VLDL. So in the situation of FCS, you don't make chylomicron remnants because you can't break down the chylomicrons because your lipoprotein lipase is low. It's not working, and therefore the liver doesn't have the substrate to make VLDL. So you see low ApoB 100 levels and very low levels of VLDL and hence low levels of LDL. And that would usually not be the case in a patient like this who has most likely multifactorial chylomicronemia. So one more quick case, and then we'll have some time to talk about diagnosis and treatment. So this is a 30-year-old female. This is my patient. I met her when she was 28. She had had 30 episodes of pancreatitis since she was 3. This was her baseline lipid level fasting. And you can see that her direct LDL was 25, so quite low. Her VLDL levels were quite slightly elevated. And she had triglyceride levels up to 2,500. And many times she knew when she got abdominal pain that she was getting pancreatitis and stopped eating a day or two before she arrived in the emergency room. So her triglyceride levels were quite variable, as already has been alluded to by everybody else. When we did her genotype, she had 2 pathogenic mutations, one in both alleles of the lipoprotein lipase gene. And both of these were known pathogenic mutations that decrease lipoprotein lipase activity. So Unfortunately, in August of 2016, she came in with the emergency room with abdominal pain and was found to be 20 weeks pregnant, which is very dangerous. As we've already stated, especially second and third trimester, triglycerides can go up pretty significantly. Her triglycerides were 3,500. And we were very worried about her having another episode of pancreatitis, not just worried about her, but worried about the baby and the potential for her to have a significant rise in her triglyceride levels during the pregnancy. Now, some people talk about being able to put folks on a really good diet and nurse them through the pregnancy, but those would be patients with FCS who responded well to an extremely low-fat FCS diet. Probably not someone who's had 30 episodes of pancreatitis is now pregnant. So we looked in the literature what the options were, and there were just case reports, one with a patient who was admitted and put on Hyper-L throughout the pregnancy. And our young patient said, absolutely not, I'm not doing that. And the other option was to place a central catheter and do plasma exchanges, which we initially started doing weekly and measuring triglyceride levels right before each exchange. So she presented with sort of the classic scenario, severe hypertriglyceridemia. She had been on multiple medications, none of which lowered her triglycerides. Her baseline level was actually closer to 1,200 versus the 750 she had previously on a fasting level. She was quite thin, low BMI, which is relatively classic. Her symptoms started at a very young age, 3 years old. She had a personal family history of recurrent pancreatitis and a sister who had pancreatitis when she was pregnant. And she had an autosomal recessive inheritance pattern as well as genetic testing proving she had FCS. And it turned out when she was really a young kid, she went to University of Chicago and they did heparin infusion and measured her lipase activity, and she had no significant lipase activity. And most people with FCS, because of the reduced production of ApoB100 containing lipoproteins and the reduced production of chylomicron remnants, the risk for ASCVD is relatively low. So we're going to talk more about the therapies, but we placed this patient on a very low-fat diet, and she was fairly familiar with that. And the symptoms, which she clearly displayed, were chronic abdominal pain. She talked about brain fog, difficulty concentrating, trouble holding a job, and difficulty with her personal life. So she got placed in an ApoC3 antisense trial, and this was after we got her through the first pregnancy. So we did plasma exchanges on her. She got through the first pregnancy, and we sent her for a study with the antisense oligonucleotide volanesorsen. When she arrived for that study, they did a pregnancy test, and she was positive. So after she delivered a healthy baby, now she was pregnant with twins. And we ended up doing plasma exchanges twice a week throughout the second pregnancy. And I talked to Dr. Gaudet, who gave me this information. He had looked at a total of, this is from Daniel Gaudet's data, he looked at a total of 42 pregnancies and 17 women who had FCS. And there were 21 acute pancreatitis episodes. Fetal mortality was 23%. And there were several maternal mortalities. And of course, the women who had prior acute pancreatitis had a much higher risk of developing it during pregnancy. Hospitalization in the third trimester was required for 2/3 of the cases. So pregnancy with FCS, not a good thing. So as I mentioned, we did her plasma exchanges. This is her plasma. So now you can understand why it's called chylomicronemia and then why it's chylous. Dr. Vartak explained that the chylomicrons are picked up by the lymphatic system, and her blood looked like chyle. So, and at the long run, after she got through her second pregnancy and had delivered 3 healthy babies on plasma exchanges, she finally got into a study with olezarsen. And when you look at the period of her pregnancies where she was getting plasma exchanges, as well as her trial, being involved in the BALANCE trial and the open label extension, she hasn't had another episode of pancreatitis over the last 8 years. And my only regret is she didn't name any of the 3 kids after me, which really hurt my feelings, but I'm going to live with it. So we're going to talk a little bit more about the signs and symptoms of severe hypertriglyceridemia, which are not specific necessarily to the diagnosis, but we already mentioned acute recurrent pancreatitis, abdominal pain, lipemic plasma, lipemia retinalis, eruptive xanthomas. This is just a picture of lipemia retinalis. Keep in mind when you look at the retina, the arteries are transparent basically, and they look red. You can see the blood in them. So you can see in this picture that the arteries actually look milky, and you can see the chylous serum in the arteries, and that is seen with extremely high triglyceride levels. Along with these eruptive xanthomas, which if you biopsy them, they have triglycerides, and the good news is they get better when you lower the triglyceride levels. So I'm going to turn it over now for a discussion of the diagnosis in patients with severe hypertriglyceridemia to Dr. Ahmad.
Yeah, thank you so much, Dr. Brown. So when we see people with very high triglycerides like these in the thousands, the main thing almost always is multifactorial chylomicronemia syndrome. But it is important to just keep in mind some of the other things because the treatment may be different. So the other things might be something like lipodystrophies, dysbeta lipoproteinemia, and like what we're talking about today, like this patient, familial chylomicronemia syndrome. So again, treatment is different for many of these conditions, so it is important to take a look or just to be careful and make sure you check for the rare things. But the vast majority of patients will have MCS, and this comes from some genetic susceptibility, almost always polygenic. Sometimes, like the first case that was presented, it's a heterozygous mutation in the same genes that cause FCS if it's homozygous or biallelic. And then these individuals can walk around with normal triglycerides, but then if they develop secondary issues like hypothyroidism, we'll have a list in the next slide, or diabetes, they can get very high triglycerides. And the prevalence is quite high. If you use a cutoff of 500 milligrams per deciliter of triglycerides, and you took everyone in Dallas-Fort Worth who has that level of triglycerides, I like to tell everyone you can fill up Dallas Cowboys Stadium. I don't know if you guys know much about Dallas. It's a pretty obnoxious place. That stadium is huge. It could fit like 105,000 people, and you could fill it up with everyone who potentially has MCS. And the good thing about this, and I guess it's good, is that you can treat this. As the first case kind of showed, the vast majority of cases respond to treatment and addressing the underlying issues. There are some that don't, and we kind of call them as persistent chylomicronemia, or some people say functional chylomicronemia syndrome. But whatever it is, the vast majority do respond. A few don't, and those might be good people for drugs in the future, or future drugs that come out. Next slide. So the list of things that cause high triglycerides is extremely long. When I do the full list, it takes me like 3 or 4 slides to actually show everything. In small font too. It's not even, I don't even use big font. In small font, you need 2 or 3 slides to show everything. But by far the things that we see the most often are diabetes, just like the first case, alcohol use, and sometimes hypothyroidism. There are many medications that also raise triglycerides. I do think that since the black box warning for hormone replacement therapy with estrogen, since that black box warning has been removed, that lipid specialists are going to start seeing a lot more cases of high triglycerides from estrogen. I mean, the vast majority of women are fine. They can take estrogen. They're not going to have a problem. But a few will have very high triglycerides, and those are the ones that are going to end up with us. Next slide. So that's MCS. We can focus a little bit on FCS. And what is FCS? You know, we wrote a expert opinion paper recently about FCS, and we wanted to make sure we give some kind of definition of what it was. We defined it as a recessive condition that's characterized by the absence of lipoprotein lipase, and that causes the persistence of chylomicrons. There's a diagram on the right. This is from our manuscript. It's not as pretty as the diagrams we've shown before, but it kind of gets the picture across. We can go to the next slide. So these are the genes that, if they have pathogenic or likely pathogenic variants, biallelic variants, they cause FCS. And we talked about all these already. Dr. Brown went through much of the physiology quite nicely, but lipoprotein lipase, ApoC2, GPI, HBP1, ApoA5, and LMF1. The vast majority of FCS patients will have a mutation identified, but up to a quarter may not. And we call those people functional FCS, and they should be treated the same way as an FCS patient. A genetically proven FCS patient. Next slide. So there's a question in the Q&A, where do you draw the line between what is a FCS and an MCS patient? Is it secondary conditions or the triglyceride level? This is a fantastic question. In most cases, there is a pretty clear distinction, and the slide that's up kind of helps you make that distinction. There are cases where it's blurry and it's hard to tell. Genetic testing helps, and we do also have a score that can help, and the score is actually really good at distinguishing the two conditions, FCS and MCS. But to distinguish the two, there's a nice table on the left here. Most FCS patients present in the pediatric age range, almost always adolescents. But we've seen even 3-month-olds and 6-month-olds with triglycerides of 6,000 and pancreatitis. FCS is monogenic, whereas MCS is polygenic. The triglyceride levels are actually a very good distinction, because FCS patients without some of the new drugs or without plasmapheresis, or without starving them, their triglycerides will always stay in the thousands. It almost never comes below 1,000 without something extreme or one of the new drugs. The cholesterol to triglyceride ratio is another good distinguisher. The ApoB level, as we discussed before, and their response to treatment is also a very good level, a very good distinguisher. Pancreatitis risk is actually a pretty good distinguisher too. Unlike the first case we had, which was MCS, the vast majority of MCS patients don't get pancreatitis. And I'm sure you guys have seen these patients. We've seen people walk into clinic with a triglyceride level of 10,000 and didn't have pancreatitis. It's not entirely clear why some MCS patients get pancreatitis and some don't. Our pancreatology colleagues have published a few things about a polygenic score, or the polygenic contribution towards pancreatitis in MCS patients. But you'll note, if the patient has had multiple episodes of pancreatitis, that does raise your awareness or your likelihood of having FCS over MCS. On the right is the scoring system that we came up with. We'll go back to that, I think, in a future slide too, but we can go to the next slide. Now, we wrote this expert opinion, and we thought it was really important to include patient perspectives, because my experience, I've been seeing FCS patients for 15 years, and this has been a really fascinating journey with them. But if you listen to what they say, you really understand what is actually important. I'm not going to read all this. You're welcome to read it at your own pace, but I do want to point out that there are many providers, even lipid specialists, who will say, oh, you don't have to do genetic testing. Well, that's fine. Technically, you don't. You can call it functional FCS. You can say clinically diagnosed FCS, but the patients want it. You can read what the patients say about it. The genetic testing helped them confirm their diagnosis. It's a big deal. If you have a rare disease, it's actually a big deal to get a genetic confirmation of the disease. And it helps with family screening. We don't always think about family screening in a recessive condition, but remember, siblings can also have the same recessive condition. And I do have one patient who was identified with FCS through genetic testing, and his sister, who was just a year old, was screened through cascade screening and turned out to also have the same exact mutations. And although the proband, the first patient, has had something like 10 episodes of pancreatitis, the first patient has only had one. And it's because she was identified early and figured out. We can go to the next slide. I think we're running a little low on time too.
Such a good point, though. I just want to comment that I've had 40 years of doing this. And in my lazy years, the first 5 or so, I said, why do we need to know the genetic disorder? Because we're just going to treat the lipids anyway. But the reality is, the risk for atherosclerosis is completely different in an MCS patient than an FCS. If the patient has familial hypertriglyceridemia, the risk for atherosclerosis is much lower than somebody who has a familial combined dyslipidemia. So understanding the disorder determines what you're going to worry about with the patient, and genetic testing has really been a huge help. So I just wanted to echo that point. And I'll let Zahid talk a little more about our scoring system.
Yeah, we touched on this in the previous slides too, and we're running a little low on time. So I'll just point out that you can find this online now, and it actually works pretty well. It's been validated in genetically proven cohorts, and it picks up genetically proven cases really well. You can go to the next slide. There are all these different, or this is from the persistent chylomicronemia paper from the National Lipid Association. Obviously, if you see somebody with high triglycerides, do a good history, do a good exam, look for any secondary factors, treat them as you would, as we've talked about, lifestyle, and then fibrates omega-3s. And if it's persistent, then it is important to refer to a lipidologist and do genetic testing and other things. And this is some more with people who have very high triglycerides that are very persistent. I'll let you all read through this. I think we're running low on time, but
the only comment I would make here, and anybody else who has comments, please do it. This defines 2 different groups: the people with fluctuating triglycerides that respond to therapy, and those with very high triglycerides that are persistent and that don't. And then the ones that are very high with persistence, who have these alarm features, recurrent pancreatitis that's not caused by secondary factors, etc. Those would be people that you would consider using the ApoC3 inhibitors on, just as you already mentioned, Zahid. They functionally act like an FCS patient. So we get into nomenclature difficulties, and this very nice paper suggests that it sort of doesn't matter what you call it. If you have persistent severe hypertriglyceridemia with these alarm features, they are appropriate for additional therapy if they don't respond to traditional therapy. And I thought it was a nice way to think about these patients when we get kind of sticklers about what to call them. Dr. Bajaj, do you have any thoughts on that?
Yeah, I think this is nice because it also, if you don't have genetic testing available or is accessible to you, just making sure that you go through, what are the clinical criteria and clinical considerations when thinking about chylomicronemia in a patient that's presenting, and what are you really concerned about in terms of risk for acute pancreatitis. And I think this breaks it down nicely. I think I would also just point out, there was a question about secondary factors and how do you define FCS versus MCS, just to make it clear. So absence of secondary factors makes FCS more likely, but presence of secondary factors doesn't rule out FCS, right? So you can still have diabetes or some of those other secondary factors in an FCS patient.
Really important point. Keep in mind that the diet is different for a diabetic than it is for an FCS patient who developed diabetes after pancreatitis. We'll talk a little more about the diet and the management section. So I'll let you comment on that, Dr. Bajaj, and you could take away the management and on the management section, and then we'll have a little time for questions.
Sure, yep. So let's start with an audience question. So what is the recommended diet for patients with FCS? Choice A, Mediterranean diet. Choice B, low carb diet. Choice C, very low fat diet. Or choice D, the DASH diet. Okay, very good. So almost all the responders got this answer correct and answered very low fat diet. Great. All right, let's go on to the next slide. All right, so just to briefly talk about the management, really the goal is to prevent pancreatitis by reducing triglycerides, so getting it out of that range where we are concerned about triggering an acute pancreatitis event, so well under the thousands that we're often seeing in patients with FCS. Really, the cornerstone of treatment for FCS is a very low-fat diet, so fat taking up less than 15% of total calories, and we usually recommend less than 20 grams per day. This is incredibly hard to follow. Traditional agents like fibrates and omega-3s and even statins for lowering triglycerides are usually ineffective in patients with FCS. And we now have 2 FDA-approved therapies. So olezarsen was FDA-approved in 2024, and this targets ApoC3. Plozasiran, as of this morning, also FDA-approved, and this is a small interfering RNA also targeting ApoC3, which I think Dr. Vartak is going to just review briefly for us. Just a couple of special cases to consider for management. So in pediatrics, really looking out for failure to thrive in the infants and using special formula. Again, that has to be a very low fat to avoid those highs in triglycerides. And then we discussed that case with pregnancy. Pregnancy in FCS is incredibly challenging to manage, requires very close monitoring and sometimes using plasma exchange as you had described in the case. But because of fluctuating hormones, again, those triggers in triglycerides is what makes pregnancy complicated. All right, Dr. Vartak?
Yes, so talking about ApoC3, this is a key regulator of plasma triglycerides. It is associated with ApoB containing lipoproteins. It is a potent inhibitor of lipoprotein lipase and hepatic lipase, and inhibits clearance of triglyceride-rich lipoproteins. So you can see why targeting ApoC3 could help you lower your triglyceride levels. This is kind of more of just what I was talking about before. So maybe for time, we can skip this slide and go to the next slide. So these are the mechanism of action for the 2 therapies that are out. So you have your antisense oligonucleotides and your small interfering RNAs. They're both nucleic acid-based therapies that target specific RNA molecules, but the mechanism of action is different. So antisense oligonucleotides are single-stranded and regulate gene expression by blocking protein translation, and eventually you get mRNA cleavage, whereas siRNAs are double-stranded trigger gene silencing by also causing mRNA cleavage, but this is through RNA interference. So we can go to the next slide. And these are the 2 medications that are approved to treat severe hypertriglycerides. So olezarsen is our antisense oligonucleotide targeting ApoC3, and plozasiran is our RNA interference agent. So I wanted to just go into a little bit about each of the studies that these drugs were involved in and talk about their effects on triglycerides. So you can see on the left-hand side with olezarsen, you had your 2 trials, the core-TIMI 72A and core-TIMI 72B. And both of these groups of patients, you had one set of patients getting 50 milligrams and another set getting 80 milligrams. And you see dramatic decreases in triglyceride percentages. You see greater than 50% for all the groups that were involved. In terms of efficacy, the majority of patients over 80% of patients saw their triglycerides fall below 500 mg per deciliter at 12 months. And also a majority of patients saw their triglyceride levels below 880 mg per deciliter at 12 months. And these are for patients whose triglycerides were above 880. In terms of safety, the 80 milligram dose was associated with some moderate AST/ALT elevations, moderate thrombocytopenia, and slight elevation in HbA1c in patients who had diabetes. And on the right-hand side, you see plozasiran, which these patients, there were 4 doses were trialed, and in each of the doses, you really see again very significant levels of triglyceride reduction. And the effects of plozasiran remained evident even at week 48, and this was 36 weeks after the last dose had been received. And in terms of safety, you saw slightly worse glycemic control in patients receiving the higher 50 milligram dose compared to lower doses and placebo, and there were no significant effects on liver function tests or platelet counts. Next slide.
So before we go to the next slide, let me just clarify something. So CORE and CORE 2 were patients that excluded FCS patients. So that was a recently presented study just 2 weeks ago at the American Heart Association. So those patients did not have FCS. They had severe hypertriglyceridemia. Olezarsen's BALANCE trial was in patients with genetically proven FCS. They didn't get quite as robust a reduction in triglycerides as you might guess, but still quite significant, over 40% reduction in those patients who are very hard to treat. So these are different groups of patients. The plozasiran data, which I assume this is from Palisades trial, these patients had a mixture of patients with FCS and also who clinically presented as FCS. Both were persistent hypertriglyceridemia. My experience has been with these drugs, if the patient is not FCS genotype, they get a little better reduction in triglycerides than those who are true FCS. I don't know what the other faculty feel about that, but so these are slightly different trials. Olezarsen had the BALANCE trial with FCS patients. This is excluding FCS patients in the CORE and CORE 2. I just want to make that clear.
And so this is the figures from the Olezarsen paper. And so you can see, and I talked about this in the previous slide, but you can just see the dramatic reductions in both CORE and CORE 2 in triglyceride levels. And similarly, at 6 months, in both CORE and CORE 2, you see greatly reduced triglycerides, greatly reduced ApoC3, greatly reduced remnant cholesterol and non-HDL cholesterol, with increases in HDL cholesterol and a slight increase in LDL cholesterol. Next
Very
slide.
encouraging in severe hypertriglyceridemic patients, even though they didn't have FCS, they didn't respond well to traditional therapy. So this was very encouraging. So thank you very much for that explanation of the data. And let me just conclude with a few items. That severe hypertriglyceridemia can be episodic. And when it is, you should be thinking maybe more multifactorial, or it can be persistent. And then as our faculty have already pointed out, that when it's persistent and never gets below 1,000, you're starting to think more of FCS, usually with triglycerides 8 to 10 times the level of the cholesterol. And then as we looked at this group in the CORE trials, they were genotype negative for FCS, but they had persistent severe hypertriglyceridemia despite traditional therapy. And they got a significant benefit from adding an ApoC3 drug. And similar trials are underway with plozasiran and now the Shasta trials. So we'll wait for those results. But just before I go on, do any of you have any additional comments about the multifactorials or the functionals without a homozygous genotype in terms of response to these therapies? Have you had any experience with that?
I agree with you. I think it's I think the patients with MCS seem to respond maybe slightly better to therapies. I mean, therapies in general. I think probably because just the underlying condition allows for a little bit more triglyceride variability, whereas FCS it's really just so elevated and fixed in their with their LPL deficiency.
Yeah, Dr. Brown, I agree. I think there, in general, yes. I believe in the Palisades study, the people who didn't have the genetically proven FCS but had persistent chylomicronemia, they still responded about the same as true FCS or genetically proven FCS. Generally, though, I think you're right. The people with FCS or people with MCS respond a little bit better than FCS.
Okay, so FCS is a devastating disease. Recurrent pancreatitis in the past. This and they still have to be on a very low-fat diet, but it really affects their life as well as their chronic symptoms and difficulty maintaining jobs and relationships. So having something that reduces the risk of pancreatitis, and I think we forget that that pancreatitis has about a 6% mortality rate. It's not a benign episode, and some of these people die from it. And so having something that reduces the risk of pancreatitis, now we have 2 FDA-approved drugs, both of which reduce episodes of pancreatitis. And unfortunately, many doctors are unaware of the diagnosis. They accuse the patients of being alcoholics. They've had their gallbladders out unnecessarily, et cetera, which just adds to the stress for the patients. And as we pointed out, MCS usually has superimposed conditions that when they're treated and the patients are put on traditional lipid-lowering drugs, they tend to respond. Especially once the triglycerides drop below 1,000, whereas the so-called functional FCS and the true genetically proven FCS patients have minimal response to traditional therapy, which gives us, more excitement about having 2 FDA-approved therapies that work in these patients. So the key takeaways, ApoC3 has been demonstrated to be an effective way to significantly reduce triglycerides. The way it does it probably is when you remove ApoC3, you can pick up intact chylomicrons by the remnant receptors on the liver, which in the normal situation you can't unless they're broken down into remnants. Plozasiran and olezarsen are now FDA approved, so the slide needs to be updated, and they've showed promise in several trials now. The goal is to reduce the risk of pancreatitis and improve the quality of life in these patients. And these patients struggle. If you ever have one, you will never forget them. You know their name and their family. And early diagnosis and genetic confirmation are key, as all of our faculty have pointed out. And the nutritional therapy remains cornerstone. We haven't liberalized the diet, even with these new therapies. So I'll stop there and we'll see if we have any questions from the audience. And I just want to thank everybody for really fantastic presentations.
Alan, we have a couple questions in the chat. I think you answered the first one. So if ApoC3 inhibits LPL, what is the mechanism of action of TG lowering in patients with FCS with total absence of LPL activity?
Nobody knows for sure, but it looks like first of all, that C3 also inhibits ApoE binding. And you remember that lipid remnant particles bind by ApoE to remnant receptors and to LDL receptors. And when you remove the ApoC3, the thought is you enhance uptake of chylomicrons by those receptors, where in the normal situation, if you don't break chylomicrons down to remnants, the liver can't take them up.
Okay, with that, I think we've answered all the questions that are in the queue. I want to thank this esteemed panel for presenting hypertriglyceridemia to us in many forms. There's information for you in the chat. I'd like to wish everybody very happy holidays. We're going to take December off from the lipid panel, and our next panel will be January 27th, 2026 on nutritional challenges. So thank you for our attendees, and thank you again to this great faculty. Have a great day.